Hello, everyone. We're continuing with the diabetes, and we were on hypoglycemia, we were on investigations, rare endocrine metabolic disorder. These may present with hypoglycemia at almost any age in childhood with hypoglycemia. The Hepatomegaly would suggest the possibility of inherited glycogen storage disease in which hypoglycemia can be profound. Investigations, blood glucose should be checked and regularly monitored in any child who is seriously unwell with reduced level of consciousness, seizures, or septicemia. Glucose measurement is often performed using glucose-sensitive sphygmometer. However, this only identifies that the glucose is low, and any low reading must be confirmed by laboratory measurement. The cause of the hypoglycemia is unknown, so it is vital that blood is collected at the time of hypoglycemia and the first available urine sent for analysis, so that a valuable opportunity for making diagnosis is not missed, since the results may only be abnormal during hypoglycemia. Treatment hypoglycemia can be corrected with the intravenous infusion of glucose to 5 ml per kg of 10% glucose bolus followed by 10% glucose infusion, or orally see hypoglycemic management in diabetes section. Care must be taken to avoid giving an excess volume, as the intravenous solution is hypotonic, could cause cerebral edema. If there is a delay in establishing infusion or failure to respond, glucagon is given intravascularly. If higher levels of glucose infusion are required, and innate low glucose is highly likely to be secondary to hyperinsulinism. And these are the tests to perform an unexplained hypoglycemia present blood. Confirm hypoglycemia in the water, blood glucose, growth hormone, cortisol, insulin, C-peptide, ketones, acetoacetate, 3-hydroxybutyrate, and bicarb, lactate, ammonia, amino acid, acyl, carnitine profile, first and after hypoglycemia, organic acids. Consider saving blood in urine for toxicology and salicylate and sulfonylureas. And hypoglycemia should be excluded in any child with septicemia or seriously has a prolonged seizures or has artistic compulsions. Don't ever forget glucose. Low blood glucose and red cell testing must be confirmed by laboratory measurement. If the cause is unknown, diagnostic blood and urine sample must be taken at a time to exclude metabolic or hormonal conditions. Corticosteroid may also be required if there is possibility of pituitary adrenal dysfunction. Thyroid disorders with thyroxine hormones produced by the thyroid gland have crucial role in growth, metabolism, and brain development. Only a small amount of thyroxine is transferred from mother to the fetus. Although severe maternal hypothyroidism, usually from dietary iodine deficiency, can cause congenital hypothyroidism. Fetal thyroid predominantly produces reverse T3, a derivative of T3, which is largely inactive after birth. There is a surge in level of thyroid-stimulating hormones, TSH, which is accompanied by marked rise in T4 and T3 levels. TSH usually declines to the normal adult range within a week. Congenital hypothyroidism is included in the universal neonatal blood spot screening program, Guthrie test, as it is relatively common, occurring in 1 in 3,000 births. A preventable cause of severe learning difficulties in the UK, screener emphasizes raised TSH when blood is taken at 5 days of age. This will only detect infants with primary hypothyroidism. However, thyroid dysfunction secondary to pituitary abnormalities, which is rare, will not be picked up at neonatal screening as they have a low TSH. In some countries, T4 is also measured. Causes of congenital hypothyroidism are thyroid age and the thyroid gland is absent. The most common cause is sporadic congenital hypothyroidism, maladescent of the thyroid, where the thyroid remains as a lingual mass or a unilobular small gland instead of migrating in early fetal life from position at the base of the tongue, sublingual to its normal site below the larynx. Dysharmonogenesis and impound of thyroid hormone synthesis without autosomal recessive inheritance in about 10% cases. Maternal iodine deficiency, a common cause of congenital hypothyroidism. Worldwide, but rare in the UK, it can be prevented by iodination of salt in the diet. Hypothyroidism due to TSH deficiency, isolated TSH deficiency is rare, 1% of cases, and is usually associated with other features of pituitary infection. Clinical features of congenital hypothyroidism difficult to differentiate from normal in the first month of life, but become more prominent with age. Treatment with thyroxine should be started before 2 weeks of age to reduce the risk of impaired neurodevelopment. With neonatal screening, intellectual development, and intelligence are in normal range for the majority of children. Treatment is lifelong with replacement of thyroxine in tablet form, titrating the dose to maintain normal growth, TSH, and T4. levels, and these are the clinical features. Hyper congenital acquired, usually asymptomatic, identified on screening. Female more than male, symptoms cold intolerance, constipation, delayed puberty, and immunology are poor. Concentration and duration of school work, learning difficulties, reduced feeding, faltering growth, prolonged jaundice. These were congenital. Prolonged jaundice, constipation, pale cold, mottle, dry skin, post feces, large tongue, horse cry, goiter, occasionally umbilical hernia, delayed development, and the signs are reduced growth rate, short stature, and unexpected weight gain, obesity, goiter, thin, dry hair, pale and puffy eyes, loss of eyebrows, dry skin, cold peripheries, bradycardia, slow relaxing reflexes, slipped upper femoral epiphysis. This is untreated congenital hypothyroidism. Identified in prenatal birth, possibly as a gut sleep. And treatment started soon after birth. Reduces risk of impaired intellectual development. Acquired hypothyroidism is usually caused by autoimmune thyroiditis. There is increased risk in children with Down syndrome or Turner syndrome, and in children with other autoimmune disorders with rheumatoid arthritis, diabetes mellitus. In some families, Addison disease may also occur. These are clinical features, systemic and eye signs, uncommon in children, exophthalmos, ophthalmoplegia, distraction, anxiety, restlessness, sweating, diarrhea, weight loss, rapid growth in height, advanced bone maturity, tremor, tachycardia, white pulse pressure, warm, vasodilated, peripheries, goiter with gluey, reduced concentration, learning difficulties, behavioral problems. Exophthalmos and autoimmune thyroiditis is Graves' disease. Clinical feature listed in box is this more common. We just read it. More common in females, there is a change in growth pattern, reduced height growth, often associated with excessive weight gain. A goiter may be present, but may be difficult to differentiate physiological enlargement in puberty girls. Thyroid function show a high level of T-cell, low level T4 and T3. Bone age is delayed. Treatments with thyroxine. Hypothyroidism, this usually results from autoimmune thyroiditis, Graves' disease, secondary to production of thyroid-stimulating hormone receptor antibodies. The clinical features are similar to those in adults. It is more often seen in teenage girls. The levels of the thyroxine and thyroxine are elevated. T-cell levels suppressed to very low levels. Antithyroid peroxisomal antibodies may also be present, which may result in spontaneous resolution of the hypothyroidism, subsequently cause hypothyroidism. The fine line of treatment is medical with drugs such as carbimazole or propiothyroxine or thyroid. Hormone synthesis, there is a risk of neutropenia from the antithyroid medication, and all families should be warned to seek help, and a blood count is also highly affected. While on treatment, initially beta blockers can be added for symptomatic bleeding for anxiety, tremor, and tachycardia. Medical treatments given for about 2 years, which should control the thyroid hormones excess, but eye signs will not resolve when medical treatment is stopped. 2/3 of patients relapse. A second course of drugs may be given on permanent remission, considered with radioiodine treatment or surgery, thyroidectomy. Follow-up is always required as thyroxine replacement is needed for subsequent hypothyroidism. Neonatal hypothyroidism may occur in infants or mothers who have hypothyroidism from the transplacental transfer of thyroid-stimulating hormone receptor antibodies. Treatment of the neonate is required and is potentially fatal, as it is potentially fatal but is resolved with the repression of maternal antibodies. Acquired thyroid disorders are less common in children than adults, and the diagnosis can be delayed as presentation is non-specific symptoms. Pituitary disorders are uncommon in childhood and can affect hormones. In isolation, growth hormone deficiency are a wider pattern of deficiencies across anterior and posterior segment of the pituitary gland. Excess hormone production from an adenoma, prolactinoma, ectopic is much less common in adult. Growth hormone deficiency, isolated growth hormone deficiency affects approximately 1 in 4,000. They are usually asymptomatic and may only be recognized when the child's measurements are plotted on a growth chart. Screening investigations show low levels of insulin, like growth factors IGF-1 and IGF-3, and a delayed bone age, but diagnosis must be confirmed with a growth hormone provocation test in which growth hormone levels fail to rise after stimulation with insulin, glucagon, arginine, and clonidine. Clinical assessment should be considered potential causes of growth hormone deficiencies, including detailed examination of the eyes as tumors or off or near the pituitary gland may result in abdominal visual fields, characteristically bitemporal myopia as it impinges on the optic chiasm. optic atrophy or papilledema on the fundoscopy. Laren syndrome is a rare condition due to defective GH receptors resulting in GH insensitivity. Patients with this condition have high GH levels but low levels of IGF-1. The downstream active product of GH produced at the growth plate and in the liver. Growth hormone treatment, growth hormone deficiency is treated with recombinant human growth hormone, which is given by daily sub-Q injection. It is expensive and management may be supervised by specialists. The best response is seen in children with the most severe hormone deficiency. Other indications where growth hormone has been demonstrated to improve final height include Turner syndrome, chronic kidney disease, shock deficiency, and in children born small for gestational age with failure of catch-up growth. Growth hormone is also indicated in Prader-Willi syndrome, where it improves muscular strength and body composition, as well as modest increase in final height. The median age for prescription of growth hormone in the UK is 7.6 years, but children with Prader-Willi syndrome are usually started at a younger age. Median 2.2 years. Recently, recombinant IGF-1 has been used to treat children with growth hormone-resistant Laren syndrome and IGF-1 deficiency who would have previously not responded to GH treatment. Recombinant IGF-1 therapy is very expensive and confined to a few specialized centers. Growth hormone excess is extremely rare in childhood. Gonadotrophin, luteinizing hormone, follicle-stimulating hormone secretion. If reduced, this may cause delayed puberty from hypogonadotrophic hypogonadism. Early increase in gonadotrophin secretion results in precocious puberty. Diabetes insipidus secondary to antidiabetic hormone deficiency. This presents with polyuria, although some children are unable to recognize this and will present with hypernatremia. The syndrome of inappropriate antidiuretic hormones can be provoked by severe illness or renal surgery and presents with hyponatremia. Adrenocorticotrophin hormone deficiency in excess, these are rare in children. Adrenal insufficiency may also be secondary pituitary dysfunction from hypothalamic HPXS disease or by hypothalamic pituitary adrenal suppression following long-term corticosteroid therapy. Okay, these are two cases. These are very important, and then we go. We will do case histories later. We will finish them and then we go to those. Adrenal disorders, primary renal insufficiency. This is much less common in childhood compared to adulthood. May result congenital adrenal hyperplasia, autoimmune process, Addison disease, sometimes association with other autoimmune endocrine disorders, diabetes mellitus, hypothyroidism, hypoparathyroidism, hemorrhage infarction, Waterhouse-Friderichsen's disease, neonatal meningococcal septicemia, X-ray, adrenal leukodystrophy, a rare neurodegenerative metabolic disorder, tuberculosis now rare. Adrenal insufficiency can be secondary to long-term use of corticosteroid therapy, for example, in treatment of inflammatory bowel disease or nephrotic syndrome. Presentation, this is of this is also case study. Presentation, infants present acutely with a salt-losing crisis, hypertension, and hypoglycemia in older children. Presentation is usually with non-specific symptoms such as fatigue and pigmentation. Postural hypotension can be flu, check lying and standing blood pressure. The child may present more acutely with hypovolemic shock and hypoglycemia during intercurrent illness. Diagnosis should be suspected from the typical electrolyte imbalance of hyponatremia and hyperkalemia, often associated with the metabolic acidosis and hypoglycemia. The plasma cortisol is low and the plasma ACTH concentration high, except in pituitary dysfunction. The diagnosis confirmed with an ACTH synactin test, where plasma cortisol concentration remains low. Feature of adrenal insufficiency, vomiting, lethargy, hyponatremia, hyperkalemia, hypoglycemia, dehydration, hypotension, pigmentation, gum, scars, and skin creases. And of course, where plasma cortisol concentrations remain low in primary adrenal dysfunction. A normal response includes adrenal crisis requires urgent treatment intravenous 0.9% saline glucose and hydrocortisone. Long-term treatments with glucocorticoid and mineralocorticoid replacement. death can occur from adrenal crisis at time of illness or injury, so a child and family are taught to give stress doses of hydrocortisone during febrile illness, gastroenteritis, major trauma, surgery, and endurance sport. Parents are taught how to inject intramuscular hydrocortisone in emergency. All children, these are buccal pigmentation, insufficiency, Addison's. This 9-year-old will present with salt craving and pigmentation. They have risk of adrenal crisis, should wear a medic alert, breastfeed or necklace, and carry steroid card. Congenital adrenal hyperplasia is the most common non-iatrogenic cause of insufficient cortisol and cortical secretion. A number of autosomal recessive disorders of adrenal steroid biosynthesis result in congenital adrenal hyperplasia with incidence of about 1 in 15,000 births. Over 90% have a deficiency of enzyme 21 hydroxylase, which is needed for cortisol biosynthesis. The majority of children are also unable to produce aldosterone, leading to salt loss, low sodium, and high potassium in the fetus. The resulting cortisol deficiency stimulates the pituitary to produce CCTH to rise overproduction of adrenal androgen presentation is with virilization of the external genitalia in female infants with clitoral hypertrophy and variable fusion of the labia. In the infant male, the penis may be large, enlarged, and scrotum pigmented, but these changes are often only noted once a diagnosis has been made. Salt-losing adrenal crisis in men who are lost salt losers. This occurs at 1 to 2 weeks of age, presenting with vomiting, weight loss, hypertonia, stability collapse. Salt-losing crisis is less common in girls, as realization is noted early in treatment, started before salt loss is significant. Tall stature in non-salt losers, both male and female non-salt losers also develop a muscular build, adult body odor, pubic hair, acne from excess androgen production leading to pronounced endarche or menstrual disorder. Diagnosis: this can be found in markedly raised levels of metabolic precursor 17-alpha hydroxyprogesterone in the blood. It's in salt losers, the biochemical abnormalities are low sodium, high potassium, metabolic acidosis, hypoglycemia. Management infant with a salt losing crisis requires sodium chloride, glucose, and hydrocortisone IV intravenously. Long-term management is a lifelong glucocorticoids, hydrocortisone to suppress CCTH level, and hence testosterone to allow normal growth and maturation. Mineralocorticoids, pseudocortisone. If there is salt loss, infants usually need added sodium chloride until weaned, monitoring of growth, skeletal maturity, bone age, plasma androgens, and 17-alpha hydroxyprogesterone insufficient hormone replacement results in increased ACTH secretion and androgen excess, which will cause rapid initial growth and skeletal maturation at the expense of final height. Excessive hormone replacement will result in skeletal delay and slow growth. Additional hormone replacement to cover illness and for surgery as they are unable to mount a cortisol stress response. Affected girls may be offered corrective surgery to their external genitalia. Decisions regarding surgery should be considered carefully, aiming for genital appearance compatible with gender and normal adult sexual and reproductive functions. This is highly specialized surgery, and definitive surgical reconstruction is usually delayed until late puberty. Prenatal diagnosis possible when a couple have had a previously affected child. In many countries, but not the UK, identification of congenital adrenal hyperplasia is included in neonatal blood spot screening program. Summary: adrenal insufficiency usually due to withdrawal for long-term corticosteroid therapy. Congenital adrenal hyperplasia are rarely a distant disease. Adrenal disease may result in an adrenal crisis requiring urgent treatment. Cushing syndrome, glucocorticoid excess in children is usually due to long-term glucocorticoid treatment for conditions such as nephrotic syndrome, asthma, or acute lymphoblastic leukemia. Corticosteroids are potent growth suppressors, and prolonged use in high dosage will lead to reduced adult height and osteopenia. This unwanted side effect of systemic corticosteroids is reduced by taking corticosteroids medication in the morning on alternate days. Non-iatrogenic Cushing syndrome is extremely rare in childhood and may be caused by pituitary or adrenal tumors. A diagnosis of Cushing syndrome is often questioned in obese children. Most obese children from dietary excess are tall in contrast to children with Cushing syndrome who are short compared to family size. If Cushing syndrome is a possibility, normal diet and a variation of cortisol high in the morning, low at midnight may be lost. 24-hour urine-free cortisol is also high. After administration of dexamethasone at nighttime, there is failure to suppress the plasma 9-hour cortisol level. The Following morning, dexamethasone suppression test. If excess cortisol production is confirmed, imaging for adrenal or pituitary tumors is required. Management depends on the source, but is usually surgical resection or radiotherapy. This is facial obesity following prolonged course of high-dose cortisone and predominant addition of oxygen therapy is being given via nasal and normal genitalia. Adverse investigator established that this was female infant. Congenital hyperplasia causing clitoral hypertrophy, choose severe hyperspadias and bilateral antisymptoms is a male or virilized female. Karyotype and pelvic ultrasound are required. And these are disorders of sex development. Fetal gonads is initially Y potential. In the male, it is the dominant gene on the Y chromosome, SY gene responsible for the differentiation of the gonad into a testes. The production of testosterone as metabolite dihydrotestosterone results in the realization of male genitalia and the absence of SY. The gonads become ovaries and genitalia female. Rarely, newborn infants may be born with the disorder of sex development, DST, and there may be uncertainty about the infant's sex. DST may be secondary to excessive androgens producing realization in a 46XX female. The most common cause of this is congenital adrenal hyperplasia, gonadotrophin insufficiency seen in Prader-Willi syndrome, and a congenital pituitary dysfunction which results in a small penis and the testes in the male. Inadequate androgen action producing underutilization in a 46XY male. This can result from an inability to respond to androgens and receptor problems such as androgen sensitivity syndrome, which may be complete or partial, inability to convert testosterone to dihydrotestosterone, 5-alpha reductase deficiency or abnormalities of synthesis of androgen from cholesterol, ovo-testicular DST, previously known as true homophorai, caused by both XX-containing cells and XY-containing cells being present in the fetus, leading to both testicular and ovarian tissues being present, and a complex external phenotype that is extremely rare. DST is a medical emergency. All parents are keen to know whether they have a boy or girl. However, the genitalia is abnormal in fixed sex must not be assigned until results are available from a detailed assessment by a medical and surgical psychological specialist. When necessary, birth registration must be delayed until this has been completed. Investigations include urgent microarray karyotype, adrenal and sex hormone levels, ultrasound of the internal structures and gonads, laparoscopic imaging, and biopsy of internal structures if necessary. And it may not be possible to determine the sexual identity of the child from the parents of the external genitalia alone. Definitely, surgery may be delayed to allow the affected individual to give informed consent to any reconstructive procedure, and gender reassignment may be wanted by the owner. The family may benefit from psychological support throughout childhood. This is a highly complex issue, and DST must be managed by experienced multidisciplinary team. If there is abnormal sexual differentiation of do not guess infant sex, the most common cause of a disorder of sex development is female realization from congenital adrenal hyperplasia. Parathyroid PTH promotes bone formation via bone forming cell osteoclast. However, when calcium levels are low, PTH promotes bone resorption via osteoclast, increasing beta uptake calcium and activates metabolism. Vitamin E promote gut absorption of calcium in hypoparathyroidism, where there is which is rare in childhood. In addition to low serum calcium, there is a raised serum potassium and phosphate and a normal alkaline phosphatase. The parathyroid hormone level is very low. Severe hypoglycemia leads to muscle spasm, tetany, seizure, stridor, and diarrhea, and vitamin D deficiency, which sometimes causes hypoglycemia. There may be bone resorption causing rickets. Hypoparathyroidism in infants is usually due to genetic disorder, DiGeorge syndrome, evolution, and hypoparathyroidism is usually another immune disorder and can be associated with Addison's disease and this bone chemistry, parathyroid disorders, vitamin D deficiency, decrease or normal, phosphate is normal or decreased, alkaline phosphate is increased, PTH increased, primary hypothyroidism, parathyroidism, it is decreased, calcium is decreased, and phosphate is increased, alkaline phosphate is normal, and PTH is markedly decreased. Pseudohypoparathyroidism, calcium is decreased, phosphate is increased, alkaline phosphatase is normal, and PTH is either normal or maybe increased. Primary hypoparathyroidism, calcium is increased, phosphate is decreased, alkaline phosphatase is normal, and PTH is markedly increased. Pseudohypoparathyroidism, there is anaerobic resistance to the action of parathyroid hormone causing a mutation in the signal molecule. Serum calcium and phosphate levels are normal, but the parathyroid hormone levels are normal to or high. Associated abnormalities are short stature, obesity, Subcutaneous nodules, short fourth metacarpals and learning difficulties. There may be teeth enamel hyperplasia and calcification of the basal ganglia, a related state in which there are the physical characteristics of pseudo-hypoparathyroidism, but the calcium phosphate and PTH are all normal. It's called pseudo-hypoparathyroidism. There may be a positive family history of both disorders in the same family. Treatment of acute symptomatic hypocalcemia is with an intravenous infusion of calcium gluconate. PTH cannot easily be replaced for hypocalcemia and hypothyroidism. Hypoparathyroidism is usually treated with calcium vitamin D analogs. So doses are adjusted to maintain the plasma calcium concentration just below the normal ranges, as without PTH, hypercalciuria and nephrocalcinosis are at risk. Hypoparathyroidism results in a high calcium level, causing constipation, anorexia, lethargy, and behavioral effects. Polyuria and polydipsia, bony erosions of the phalanges may be seen on a hand radiograph in neonates and young children. It is associated with some rare genetic disorders, Williams syndrome, but in later childhood can be secondary to adenomas occurring spontaneously or as a part of multiple endocrine neoplasia syndromes. Severe hypercalcemia is treated with rehydration, diuretics, and bisphosphonates. So this is the sex development, male undifferentiated gonads, sex determining region of bicobs, gene, testes, Leydig cells, and Sertoli cells, Leydig cells, testosterone, 5-mg reduce them to testosterone, virilized external genitalia, testosterone also has maintains male internal genitalia, vas cord 700 cycles, and Sertoli cells endocrine hormone inhibits uterus and fallopian tubes, and differential gonads in females, no sex determinants of gene, ovaries, and female genitalia. So these are normal appearance of newborn infant genitalia as is shown. Investigation between normal female karyotype for the sex presence of the uterus on ultrasound examination, markedly raised plasma, creatine and hydroxyprogesterone, metformin, congenital adrenal hyperplasia, low sodium and high potassium level, low bicarb, metabolic acidosis, high urea dehydration, low blood glucose, cortisol deficiency. The low sodium and high potassium indicate that the infant had the salt-losing form of congenital adrenal hyperplasia. She required correction of hyperglycemia, hypoglycemia with IV glucose that was started on oral hydrocortisone and fluorocortisone replacement therapy. Her growth, biochemistry, and bone age was monitored frequently, and she attained normal adult height. Psychological counseling and support were offered around puberty, and gender surgery was needed before she became sexually active. This is the congenital adrenal hyperplasia, mineralocorticoids, corticosteroids, and increase ACTH, increase cholesterol, and then progesterone, and then increase centine alpha, hydroxyprogesterone, and then increase testosterone. And there is a block in 20 alpha hydroxy that converts progesterone into aldosterone, that decreases, and centine alpha hydroxyprogesterone that makes corticosteroids and aldosterone. So mineralocorticoid sex hormones are congenital abnormal adrenal steroid biosynthesis from 20 alpha hydroxy deficiency. The most common form of congenital ACTH is the most common form. And diabetes insipidus, a 5-year-old presented with thirst and a normal blood sugar. He's drinking water excessively both day and night. With recent recurrence of bedwetting, on admission to hospital, his fluid input was 7250 ml and output 7720. He had a raised pulse of sodium of 127, a serum osmolality 298, normal is less than 295. His urine osmolality 125, demonstrated an ability to concentrate. His urine sometimes water deprivation test is needed to confirm diagnosis. Examination including vision freeze were normally responded to a small dose of desmopressin with a major reduction in his urine output, confirming diagnosis of cranial diabetes insipid. MRI pituitary gland shows a small lesion in pituitary stalk consistent with histiocytosis. Demonstrate a homogeneous enhancing infant developed pituitary stalk mass and active contrast. Okay, this is the mass, pituitary mass, and there is growth hormone deficiency. This boy presented with short at the age of 6 years, small for family size with a height of 102 centimeter, less than 0.4 centile. His weight was 17.8 kg with on the second centile. His bone age was late 2.5 years. He underwent pituitary function tests, including growth hormone provocation, using glucagon to provoke B1 hypoglycemia, simulate growth hormone production. His peak growth hormone level was low, 1.7 mics, normal more than 6.7. Other hormone including cortisol showed a growth response. This confirmed isolated growth hormone deficiency. He started growth hormone. He responded well to daily sub-Q injection, reaching height of 120 by the age of 8 years and 8 months. This was plotted, growth hormone therapy, plotted chart. Rosha shows this boy was growing below 1 percentile and his weight on the 30 percentile. So this is it for endocrine. Thank you very much.